It's four.
Hello, everyone. Good afternoon. We will back again in ASPA Pediatric Pain Special Interest Group webinar series. And this lovely afternoon, we will have our last webinar series in this year, which the title is Oncology and Palliative Pain in Children. We will have 3 speakers and 1 moderators for this session. And I hope you enjoy all things. First, let me introduce you to our moderator, Dr. Anuradha Ganigara from India. Dr. Anu is the Associate Professor from Department of Anesthesia, Indira Gandhi Institute of Child Health, Bengaluru, India. She has interest in pediatric pain management, including acute chronic palliative care service in children. And also she interest in innovation in anesthesia equipment. Dr. Anu, the screen is yours.
Thank you, Dr. Adi. Am I visible and is my audible as well? And can you also see my screen? Too many questions at one go.
Yes.
Okay, give me a minute. Yeah. Okay, thank you for this wonderful introduction. So good afternoon to all of you who have joined us. I can see there are 40 participants. That's amazing on a lazy Saturday afternoon. Thank you so much for joining us. And a very warm welcome to all of you. So I think it's a perfect coincidence that we are conducting this last webinar, which is a part of a 4-webinar series on pediatric pain on the World Hospice and Palliative Care Day. And the topic of today's webinar is palliative care in children. So it's an amazing and a perfect coincidence. And this is thanks to one of our panelists, Dr. Spandana, who for educating us on this very important date and the importance of this event. So I just wanted to take a minute to talk about today the World Hospice Day. The theme is compassionate communities and caring for palliative care. So what I would want you to reflect is palliative care is not just end of life care. It is care to help people live well in the time that they have. So it's like think of it. Do not count the days. Make the days count. And just a small tidbit. So this is the second webinar that we are having this year, and we have an all women's panel. So I must really admit, I enjoy working and collaborating with all these fantastic and intensely passionate and driven women who make so much of a difference in everyday lives of children for whom pain is a big thing. They make it matter, and obviously the work to make it better. Thank you so much to all the speakers for joining us in today's webinar. So I have a quick poll question for the audience. I should have probably given you a heads up, but if you have an extra device, you can scan the QR code. And because this is like a little heavy topic, you know, when you talk about palliative care, more so when you talk about pediatric palliative care, it's just an tense, uneasy atmosphere. So I would want to know what are the words, the thoughts, and the various things that come to your head when you think about palliative care, more so pediatric palliative care. I'll give you a minute to respond. You can also scan the link which is on the left-hand side of the screen and just type in your responses. Take your time. Yeah. That's lovely. That's an awesome word, comfort. Yeah. I hope you're not having issues with scanning the QR code. I see some more words popping in. That's great. I should probably educate myself about how frequent these words are used, and does it become bigger with the more number of times that it is put in or typed in? How does it work? But so far, I can see quite a few words: suffering, free, sad, comfort, pain, decrease. All these are perfect, great words. And I'm glad you're able to connect with this thought that, yeah, I see more of comfort. Uh, what I would also like to say is probably, you know, when we look at pain or cancer pain or talk about palliative care issues in children, we get these ideas, you know, they're frail, weak looking children with bald heads. And but what we need to keep in mind that these children are living their everyday lives like this. And as palliative care physicians, it's our job to make it better for them. So yeah. Uh, can I close this poll now and go to the next slide, please? So what I would like, you know, mention is just about the Buddha parable, wherein Buddha consoles his disciple who has lost her only child, young son, and he tells her, "I can let this child live, provided you get me some mustard seeds from a home, from a household where death has not is untouched." And so this lady goes around asking in the village for from households where there has been no death, and she comes home empty-handed. So that is when she realizes the impermanence that Buddha so strongly speaks of and the ubiquitousness of death. So in palliative care, we need patients whose problems we cannot fix completely. We cannot make their diseases go away like in a quick spat, like a magic patch or something, like the way these other curative and preventive branches of medicine talk about. But what we can do is to make good of whatever time is left for such patients and their families. Uh, on the same thought, what worries me more is, at least in adults, the palliative care is, you know, well established. It is entrenched in today's society. But when it comes to pediatric palliative care, it is hardly heard of. And this is thanks to human psychology. Like we as humans, we probably, it's like an avoidance strategy that we do. We do not want to listen to or look at things which cause distress in us. So I think the goal of today's webinar is obviously to have this tiny pediatric voice amplified on the World Hospice and Palliative Care Day today. So before I hand over the online podium to our esteemed speakers, I'll quickly run through some housekeeping rules. So one is regarding the Q&A questions for or the audience who have joined in earlier. You know, this will be at the end of the webinar. The chat and raise functions are disabled. You can type in your questions and Dr. Addy and myself will highlight your questions to the speakers. We are also happy to answer it by text whenever possible. Whenever, yeah, like you responded to the poll question, so I'm not going to use this. You'll just have a QR code, scan it and put in your answers. This is just a disclaimer again. that this presentation is mostly for educational purposes. These views are not necessarily did not reflect the opinions or policies of institutions or organizations, and this may not be applicable to in all situations as well. And if you like our content and want to follow us, then please do tune into the ASPA website, Facebook, or YouTube. It's a recorded session. So this is just yet another one more poll question. So this is just, we want to know what is the audience that we have today. So what describes you the best? Go ahead and type in your answers. You can use the QR code, or there is also a link which I'm happy to share in the next slide. I'll give you like 30 seconds to share this. To scan the QR code and type in your answers, please. That's great. I hope you're able to see all the other options. Looks like mostly it's an anesthesiologist crowd. Yeah. Yeah, I'll close this poll, I guess. Glad to know that so many anesthesiologists who are interested in pediatric palliative care. I'm sure it's going to be like, we are making progress, and this is going to be sustained. Oh, we do have, just give me a minute. We do have some pediatricians as well, interventional radiologists, awesome. Okay. Thanks everybody for all your answers. We have had a small, tiny, just a minute, I think my slides are not moving. Sorry. Just give me a minute. For some reason, my slides are not moving. I'll just stop sharing and then go back. Yeah. Yeah. I'm just going to hand over the online podium to our first speaker, Dr. Komal Tiwani, who's joining in all the way from the Singapore KK Children and Women's Hospital. She's a senior consultant and head of Women's Palliative Care Service. This also includes the gynecological oncology and perinatal palliative care at KK Women's and Children's Hospital. Her areas of interest are palliative care, perinatal palliative care, dignity and personhood in healthcare, end-of-life care, and spirituality. So she's going to be talking about cancer and non-cancer pain in neonates. Yeah.
Thank
I'll
you.
stop.
Yeah, thank you, Dr. Anu, for the introduction. And thank you all of you for joining on a Saturday evening, spending precious time of your weekend listening to this webinar, and hopefully we can make it worth your while. So I'm going to be speaking mainly about neonates, and discuss a little bit about pain in neonates. Okay, so the agenda is, I know that this is one of the last webinars of the year, and you have already had detailed discussions about pathophysiology of pain, as I have been told by Dr. Madhvi, and also you have had a separate session on neuropathic pain. So what I'm going to do is speak a little bit about the pathophysiology of pain, but in relation to the developmental neonatal physiology, so that it makes a little bit more sense. And then I'm going to talk a little bit about the evidence and show you why it is important to treat every episode of pain you encounter effectively. Then we'll talk a little bit about the important neonatal physiology, keeping in mind things that you need to consider while starting any pharmacological management. And then afterwards, we'll talk about validated tools to identify pain in neonates. And finally, we'll go to the management, non-pharmacological as well as pharmacology. So some useful concepts we all know about nociceptors. They are specialized sensory receptors responsible for the detection of noxious or unpleasant stimuli, transforming these stimuli into electrical signals, and which are then conducted to the central nervous system. I'm already talking to the converted, because from the poll we saw most of you are anesthetists and you're very well aware of this, so we won't spend a lot of time over here. But I want to highlight to you that there are these primary afferent A, delta, and C fibers which are distributed throughout the body, and they are stimulated by mechanical, thermal, or chemical stimuli. Now, in addition to the A delta and C fibers that carry the noxious or the unpleasant sensory information, we also have the A beta fibers that carry the non-noxious stimuli. And each of these fiber types, it possesses different characteristics that allow the transmission of a particular type of sensory information. So just to explain to you in a table, the A beta fibers, they are large, they are highly myelinated, and they carry the sensation of light touch and non-noxious or not unpleasant sensations. So we should be very thankful for that. Imagine if these large, highly myelinated fibers carried the pain sensation. How much more would the pain be actually perceived? And why I'm talking about it is because in the neonates, we have the fibers which are not so myelinated. And as we can see here, the A delta and the C fibers, they are the ones which actually conduct the noxious stimuli. The A delta fibers, they are thinly myelinated and they actually carry the sharp localized pain sensation, whereas the C fibers, which are unmyelinated, they carry the sensation of dull pain. Now, pain is mediated through both these peripheral and central mechanisms. And in nociceptive pain, peripheral nociceptors, they are stimulated. They transmit the pain through the pain fibers to the dorsal horn of the spinal cord and then to the thalamus and to the cortex. Pain is perceived in the thalamus, but emotions connected to this are actually perceived in the cortex. And pain transmission is a result of complex peripheral and central processes. Now, these processes can be modulated at different levels of the spinal cord, particularly at the dorsal horn of the spinal cord and via the descending inhibitory pathways. So even though we have the ascending pathways which carry the sensation of pain, we are lucky to also have these descending inhibitory pathways, which may not be so well developed in neonates. Yeah. So pain perception is a result of the balance between these facilitatory and these inhibitory interactions. Now, coming to the developmental phase of neonatal physiology, we have evidence that cutaneous nociceptors, they are developed between 7.5 weeks to 15 weeks post-conceptional age. So imagine just when the yolk sac is forming and you can see the beating heart at 7 weeks, that is the time that, cutaneous nociceptors are already developing. And very strong reflexes to tactile and noxious stimuli can be seen from the first trimester, because there is already established circuitry for the nociceptive spinal reflexes. Now, these sensory signals, however, they do not ascend to the cortical level until much later, that is the age of viability, around 24 to 25 weeks. And the cortical discrimination actually occurs more towards term, around 35 weeks. Yeah? So now we have discussed a little bit about the pathophysiology of pain and a little bit about the developmental neonatal physiology. I want to emphasize to you in the next couple of slides why it is important to treat every episode of pain that you encounter effectively. So after centuries of scientific opinion stating otherwise, it is now thought that neonates, even premature newborns, they experience pain. The view that neonates cannot experience pain because of the immature myelination is no longer accepted. Like I explained previously, the research has found that in fact nociceptive impulses are carried through the unmyelinated and the thinly myelinated nerve fibers. And although the conduction is slower, definitely in neonates, the conduction is not as well established as in adults. But there's a shorter interneuron and neuromuscular distance in newborns. So that compensates for the slow conduction. I mean, the baby is so small. So from the peripheral nociceptor all the way to the CNS, the distance is much shorter compared to an adult, So, but that shorter distance compensates for the slow conduction. So they still feel, appropriate amounts of pain as compared to an adult. And maybe more because, like I said, the inhibitory mechanisms are not so well established. Another view that neonates and young children cannot experience pain because they lack the painful memories to provide the emotional context for the painful stimulus is also countered. And actually, the inadequate treatment of pain in young children has been found to have an enduring impact on the future experience of the child's pain. So, we feel that, the emotional context of the pain actually the child doesn't have, because the child has, is brand new, hasn't actually had these experiences. But see, if you don't treat the pain on that episode, the child will develop these emotional context to painful stimulus. And there has been research to show, like for example, in this paper, which was actually published in the Lancet, that infants who were circumcised without anesthesia as neonates, they showed increased distress during routine immunization at 4 and 6 months of age when compared to uncircumcised infants or infants who were circumcised as neonates, but they were in which their team had actually used good topical local anesthetics. And even among neonates and young children with newly diagnosed cancer, sometimes you have babies born with a posterior fossa tumor, and they need to start a lot of treatment early on. Those who have inadequate analgesia during their first bone marrow or first lumbar puncture, they showed more severe distress during subsequent procedures than those who received a potent opioid during the first procedure. So what I'm trying to say is that if we fail to alleviate pain, we will cause needless suffering. And with this failure to alleviate pain will also cause adverse physiological consequences in the child and maladaptive behaviors. So when you're treating one particular pain episode effectively, you are avoiding those adverse physiological consequences, and you're avoiding or preventing the generation of maladaptive behaviors towards pain. And pain is the most prevalent symptom, and it concerns a lot of parents. I work in perinatal palliative care, where in the antenatal period itself, the mother knows that the fetus has a lethal condition. And most of my parents, universally, across various ethnicities, across various religions, across various financial statuses, across various educations, they all have the same sentiment, that we understand that our baby is not going to be with us for long, but please make sure that my baby doesn't suffer and doesn't experience pain. And the pain in the baby is distressing to the baby, distressing to the parents, but also distressing to the professionals who are looking after the baby. I mean, I've had nurses who have, called me up and down because they feel that the baby is not comfortable and the baby is crying. It's very distressing to the professionals on the ground looking after this baby also. So hopefully we have sort of like understood a little bit about the importance of, treating every episode of pain with the respect that it deserves. We'll talk a little bit about the neonatal physiology, so that these are the things you need to keep in mind when you start the pharmacological management. So let's come to the age-related physiological things that we need to keep in mind in neonates. When it comes to body compartments, now neonates, they have decreased fat, they have decreased muscle, but they have increased water. So increased volume of distribution of water-soluble drugs. So what does that mean? That means that the duration of action of these water-soluble drugs will be longer. Then we come to plasma protein binding. Neonates, they have decreased concentration of albumin and alpha-1 acid glycoprotein. What does that mean? That they have an increased ratio of the unbound or active drug. So you have to keep that in mind. Then we come to the hepatic enzyme system. Neonates and infants, they have immature hepatic cytochrome P450 subtypes and glucuronidase transferase. So what does that mean? That the drug will be having a longer duration of action. And what does that mean for us? That we need to make sure that we interval the drug at a longer duration. That means the frequency of the drug has to be a bit longer. And for neonates and infants, they also have a decreased glomerular filtration rate. So accordingly, we have to increase the duration or frequency of the drug that we administer. And another important thing when it comes to the oxygen consumption and respiratory function, because, when we use opioids, we're always worried about respiratory depression, and we have to be more careful in neonates, because neonates and infants, they have increased oxygen consumption. They have an increased ratio of oxygen consumption to the functional residual capacity. They also have decreased fatigue resistant diaphragmatic fibers. That means the diaphragm can get fatigued very easily. They obviously have a small airway caliber, how tiny they are, some of them. So imagine the airway caliber. Increased resistive work of breathing. They have decreased pharyngeal and lingual muscle control. They also have decreased rigidity of the larynx and subglottic trachea. That's why actually ketamine, clonidine are never used in children who are not ventilated, because they can go into laryngospasm. And they have decreased ventilatory responses to oxygen and carbon dioxide. So after speaking a little bit about the neonatal physiology, I will go on to the validated tools that we use for assessing pain in neonates. So the FLAC scale and the CRI scale is something that we use in my institution, but I'm going to highlight to you all the validated scales so that you can then decide for yourself what is more appropriate for you and your institution. So I'll be talking a little bit about the FLAC scale and the CRI scale in the next slides, but let me just mention the premature infant pain profile. That's the PIP scale, neonatal infant pain scale, and the pain assessment tool. I've given you the evidence for that, and you can look it up and then see what works best for your team. We use the FLAC scale in our hospital, and the FLAC stands for face, legs, activity, cry, and consolability. And each of this is graded as 0, 1, or 2, depending on the neonate. Higher the score, more the pain. The CRI scale actually was designed to measure post-operative pain in neonates, but it is very frequently used to assess pain in patients in the NICU, and it can provide a very useful guide for assessing pain resulting from other causes in the neonatal population. This scale consists of 5 physiologic and behavioral indicators, each of which can be rated as 0, 1, or 2. Maximum score is 10. Again, higher the score, more the pain. C stands for crying. R for requiring oxygen for normal saturation. I for increase in the vital signs, for example, tachycardia, expression of the neonate, and the sleeplessness of the neonate. So I want to highlight this important point. Now, if the neonate is obtunded and critically ill, you're not going to have behavioral indicators like facial grimacing or crying because the neonate is, quite sick. In that case, you may have to rely on people who have actually worked with or dealt with this neonate for some time to have an idea of, how much pain this person has. So the nurses looking after the neonates, I always make it a point to talk to them and find out what do they feel, because they spend the maximum time with the baby. So finally, we come to the part of management, and we will always want to emphasize non-pharmacological management in neonates. Even while you're doing the pharmacological management, please do not ignore the non-pharmacological management, especially in this age group of neonates. Swaddling helps a lot. Pacifier, latching to the mother if possible. Kangaroo care and skin-to-skin care we encourage in our NICUs. Now, calm environment is a challenge in the NICU with beeping machines and, the traffic of people, especially nurses, the ratio of nurses to babies is quite small. But even then, as far as possible, we try to dim the lights and, reduce the noise as much as possible. Massage and therapeutic touch, music therapy. We actually have a music therapist as part of our team. Again, resources for various countries are different. You may actually have to make do with the services or, with the kind of help that you have available. But, I've had experience of working in India and, working in other countries in which, they're not as advanced or they do not have the resources that, many first world countries have. But I think the passion of the people doing the work sort of like compensates for that. And of course, all these non-pharmacological measures are then accompanied by pharmacological therapy. So in the management of pain in neonates, we actually have only 2 steps. We don't use the mild, like the tramadol codeine. So the medications that I usually use are the ones that I have sort of like described over here. So if the baby is having acute but non-persistent pain, I usually prefer the oral or the buccal route as much as possible. Oral sucrose for babies more than 32 weeks, 0.5 to 2 ml of a 24% sucrose orally. Preterm babies, I give a maximum of 4 doses in 24 hours. If the baby is term baby, then 8 doses in 24 hours. Again, another thing we use commonly is, oral and rectal chloral hydrate. For sedation, we usually use the dose of 10 milligrams per kg per dose every 6 to 8 hourly. Don't worry about these doses because you will be having the recording of these slides and also the, the APPM or, the guidance for neonatal care, which is published, which I can share the link, has all the doses of various medications that we use in neonatal palliative care. So for analgesia, usually I use 25 to 50 milligrams per kg per dose. And so whenever I start a painkiller, I always give a loading dose first, because the baby has been in pain for some time. You want to control the pain first. And then after that, I put a maintenance dose. So always a little bit higher loading dose and then the maintenance works very well in my practice. Yeah. And then maintenance with 10 milligrams per kg per dose every 8 hourly. Always administer chloral hydrate after feeds because otherwise it causes a lot of gastric irritation. Paracetamol is one of the most simplest and most frequently used medication. In neonates, 28 to 32 weeks of corrected gestation age, we use about 20 milligrams per kg as a single dose and then 10 milligrams per kg every 8 to 12 hours as required. Maximum dose of about 30 milligrams per kg per day. And neonates over 32 weeks of corrected gestational age, we use 20 milligrams per kg as a single dose and then 10 to 15 milligrams per kg every 6 to 8 hours. Maximum dose being about 60 milligrams per kg per day. So paracetamol, we are lucky. We have rectal, oral, as well as, infusion. So rectal also in neonates, 28 to 32 weeks post-menstrual age. So this is the first day of your last period. So even though the baby is smaller, we can still use rectally 20 milligrams per kg as a single dose and then 15 milligrams per kg every 12 hours as required with a maximum of 30 milligrams per kg per day. And for neonates who are more than 32 weeks post-menstrual age, we use 30 milligrams per kg as a single dose and then 20 milligrams per kg every 8 hours as required with a maximum dose of 60 milligrams per kg per day. Now IV, most of our babies in the NICU, they usually have a line. So we always try to use the IV line as far as possible because it's already present and it's convenient. As far as possible, I try to avoid subcutaneous if the if possible. But definitely intramuscular is a no. We don't use intramuscular route for neonatal palliative care. So IV Panadol or paracetamol, we give in neonates more than 32 weeks of corrected gestational age, about 7.5 milligrams per kg every 8 hours. We run it slowly over 15 minutes. So it's not a bolus dose, but we run it through a burette over a period of time, which is 15 minutes, with a maximum of 25 milligrams per kg per day. And term neonates, that means who are more than 37 weeks, we give the usual dose, 10 milligrams per kg every 4 to 6 hours. Again, run with a burette over 15 minutes, with a maximum dose of 30 milligrams per kg per day. Now, if the child has some renal failure, then we keep the frequency as 6 hourly. And if the renal failure is worse, then we keep the frequency as 8 hourly. Now, oral ibuprofen, it's not licensed actually, so it's off license use. We use 5 milligrams per kg per dose BD or 3 times a day. Now, if the child has a duct-dependent congenital heart disease, you do not want to give ibuprofen because you will close the ductus arteriosus and that will put the child in distress. Clonidine, again, I want to just mention, I only use it when I want to have a sort of like an opioid sparing effect, or if the baby is already having opioid withdrawal, then we use it. Usually oral or intranasal through an atomizer, 4 mites per kg, and rectally 5 mites per kg. Subcart and IV I only use if the child is already ventilated. And the dose is 0.25 mites per kg per hour. I increase by 0.1 mite per kg per hour. Monitor BP because clonidine causes the BP to rise. And if you have given clonidine for some time and you want to stop it, make sure you taper it because otherwise there'll be a rebound, raised blood pressure. And finally, we come to the opioids, morphine, which is the step 2, or, if the pain is really bad. So usually oral morphine, 25 to 50 mites per kg every 6 to 8 hours. And subcard and IV, we can give as a single dose, 25 to 100 mites per kg per dose over 5 minutes. And then as required every 4 hourly. Sometimes we start a continuous infusion, usually IV, very rarely subcard, with a loading dose of 100 mites per kg per dose over 1 hour, followed by a maintenance of 10 to 20 mites per kg per hour. And fentanyl, we also give buccally. So now what we are using for buccal is actually the injection solution, which we actually use buccally or intranasally with the atomizer. Otherwise, it can sting. And we use at a dose of 1 mites per kg per dose. And if it is a subcard or IV, about 0.5 to 4 mites. Usually, I start with 1 mite per kg per dose PRN up to Q2 to 4 hourly over 30 seconds. And if it's a continuous infusion, then about 1 mite per kg per hour. So, in managing neonatal pain, it's in the definition of palliative care. You need a meticulous assessment. And definitely, I have to emphasize that when it comes to neonates, you need to be meticulous in your assessment. Individualized treatment. Obviously, if the neonate is towards end of life, you may want to use opioids at a bit, because you have very little time to make the baby comfortable before he or she passes on. So you may want to be a little bit more aggressive. Whereas, if the baby is otherwise stable, you may take a little bit of time to titrate the medication. So individualized treatment and regular reviews using the varied skills of a multidisciplinary team and good communication between healthcare professionals and parents is essential. Usually after I start medications, I always go back 30 minutes to 1 hour or one of my team members. And I not only review the baby, but I also speak to the nurse and the parent who's looking after the baby to understand what is their perception. Do they feel that the pain is better? And then I decide, if I want to continue, I need to escalate the medications further. Now, just one of my last slides, because everybody is worried about, respiratory depression. It's the most feared. The other opioid side effects already. But let's talk a little bit about respiratory depression. Now, remember, respiratory depression is not just the reduction of the respiratory rate, but it's also the increase in the PCO2 and the fall in the oxygen. So sometimes what happens, pain is a very effective respiratory drive stimulant. So when the pain is relieved, obviously the baby is more comfortable and the breathing rate may become a bit slower. But if the baby is saturating well, you don't have to worry about respiratory depression. The moment I see that, the respiratory rate has gone down, immediately I'll be getting calls that, the opioids have been started, RR has gone down. And then you have to explain to them that, no, what is the saturation of the baby? So opioid-related respiratory distress is something we have to be very careful in neonates, particularly because of the neonatal physiology that I explained earlier. But always remember that it is, not as common as people fear it to be. If you are doing your escalation very mindfully and in a slow and progressive way, you don't really have to worry about it. And opioid-related respiratory distress is always preceded by sleepiness and decreased consciousness. So we know that opioids can impair the CNS respiratory drive, resulting in alveolar hypoventilation and inability to adequately eliminate the CO2. That's why it rises. And eventually the exchange of oxygen, and therefore the oxygen level goes down. But it is important to understand that in the final phase or in a terminal illness, babies often become less responsive, and they develop different or irregular breathing patterns and apnea. This could be part of the dying process. And here we use the doctrine of double effect. We are giving the opioids to make the baby comfortable. It may be possible that the baby may pass away a little bit sooner than what he or she would have had we not started the opioid. So that is the doctrine of double effect, which is very different from euthanasia, where you give a medication just because you want to shorten the life. So I always like to be truthful to the parents and tell them that yes, these medications are serious and we are going to be using it very judiciously, but there is a possibility that the baby may be comfortable but maybe sleeping and may pass away, so that they are aware. So I think that's about it for me, and thank you very much.
Hello. Thank you, Dr. Komal, for that wonderful talk on I think it's a difficult topic to talk about, palliative care in units, and you've done a wonderful job. Thank you so much. I would like, and I also, please stay with us online because we're going to be taking questions at the end of the webinar. I would like to call upon our next speaker, Dr. Madhvi Desai, who will be talking about different kinds of pain in children with oncological issues. So, are you able to see my slide? Dr. Madhvi Desai is an associate professor in the Department of Anesthesia and Critical Care and Pain at Tata Memorial Hospital, Mumbai, India. Her areas of interest are pediatric onco-anesthesia, pediatric NORA, acute postoperative pain, neuro-onco-anesthesia. She's been a certified PALS instructor since 15 years, and she's also been an editor of MCQ's book for postgraduates in anesthesiology. I would like Dr. Madhvi to start. She can share her screen. If you're having any issues, please feel free to ping me your message.
Just a minute. I had some problems with my Zoom. Good afternoon. So I will just take few seconds. Otherwise, Anuradha can start sharing the slides.
Lovely.
Yeah. Are my slides visible? No.
No, not yet.
Okay. Anuradha, can you share the slides then?
Yes, I'll do that.
Okay, thanks.
Are they visible now? I'll just go to the full screen.
Yeah, they are.
Yeah.
Oh, thank you. Good afternoon. So the last month, September, also is a cancer awareness, pediatric cancer awareness month. So this was a good occasion to speak about the pediatric cancer pain, which is less addressed as compared to the other pains and the even adulthood cancer pains. So some overview regarding the common childhood malignancies. They are the distribution of malignancies in adulthood and childhood are different. As you can see in adults, there are more solid tumors. But in children, the predominantly what we see is hematolymphoid tumors. They are the leukemias and lymphomas, and around 60 to 80% of the leukemias are the acute lymphoblastic leukemias. The cure rate, if they are diagnosed in early stage, is almost 98 to 100%. And the incidence you see in toddlers at the age of 2 to 3 years. Followed by 10% of childhood malignancies are lymphomas. And you see Hodgkin lymphomas in the age during 10 to 14 years. The solid tumors are around 30%, and most of them, they are embryonal tumors. Embryonal tumor means they are generated from the blast cells during the development of the embryo, and they are all, you will see all those blastomas, medulloblastomas, neuroblastomas. Wilms is nephroblastoma or liver hepatoblastomas. The presenting age for these tumors is around 0 to 3 years. So you will have small infants and toddlers coming with these tumors. The other tumors coming up at age of 5 to 6 are around the medulloblastomas and ependymomas. They are the brain tumors. So if we see here, the bone and soft tissue tumors like they are less seen in children, and when they are seen, the child is around 10 to 15 years. So it is a model of cancer pain overall in adults and children. It is not just the treatment of one thing. It starts from the screening investigations. The patient undergoes or the child undergoes multiple procedures, diagnostic procedures to reach to the conclusion and mapping of the disease. So the same child will be posted for CT scan, then bone marrow biopsy or a lymph node biopsy, multiple blood tests, again going under through the pricks, then reaching to the conclusion and diagnosis. Then comes the disease related treatment, which could be surgery or chemotherapy or radiation. And uh, uh, each aspect of the treatment is associated with a good amount of pain. Then comes, if the pain goes in the metastatic disease, again the pain of metastasis. And at the end, it's a terminal pain of during the palliative stage. So what is a therapy in oncology pain? So it is the complete therapy of all stages and not just peri-procedural or peri-surgical pain management. So as I said, it is the pain management of disease itself. Then it needs a pharmacological therapy, yes, of course. And along with that, it needs a good practice of non-pharmacological therapy. And I think Dr. Spandana will be focusing more on that. And we have to remember here that it is not a single one episode of surgery or something here. It is continuously ongoing procedures and ongoing diagnostic procedures, ongoing pricks, ongoing therapies. So in case there is any time unpleasant experience by the child, or there is an inadequate pain management, it decreases the compliance with the further treatment of the cancer. So I will be briefly introducing all these issues. In the diagnostic procedures, as I have discussed, multiple pricks, punctures, biopsies. Then there is what are the issues with the disease related pain? So the solid tumors, they will come for surgery after some amount of a chemotherapy or some regime of the chemotherapy. The problems here are, one is a peri-procedural or post-operative acute pain. The second is, as anesthetist, what we encounter is these children, they are just recovering from the neutropenia and the cell counts and cell lines. So their platelets are improving, the neutrophil counts is improving, and they are then posted for the surgery during a phase when they are just optimum to be taken up with good counts. In most of the surgeries, even the post-operatively, the chemotherapy is resumed within 1 week. So again, the cell line and counts drop. So it is, whatever intervention you are doing, we have to keep in mind, for example, epidural. And we have to keep in mind that maximum you can keep for 3 to 4 days. After 1 week, they go for chemotherapy. And in literature, there is very small review about what should be the minimum counts to undergo for the epidural punctures or CNS punctures or even the continuous catheter infusions for that. The ASPA has definitely guidelines for platelets, but there are not guidelines regarding any white cell counts, which are responsible for managing or taking care of the infections perioperatively. The other issues are, these are most of the time major surgeries which involve the massive blood loss. And again, they may have post-operative, their coagulations may be affected post-operatively, and the removal of the catheters could be a problem. So it is a very challenging situations. The other is chemotherapy related issues. They cause severe mucositis, then chemotherapy induced peripheral neuropathies, and also the infection during their neutropenic phase. And because of the infections, the child develops many abscesses and requires a lot of pain management for that. So is the cancer pain different in a child than in adult? Yes. The mucositis after the chemotherapy and radiotherapy is very severe in child, and they really drop down on their oral intake. They become hypovolemic, they become hypotensive, and it can be actually emergency with which they can be admitted to the ICU. In that, you have to manage your pain management. Then, of course, there are procedure-related pains. Post-operative pain, as I discussed. Chemotherapy-induced pain, I'll be talking shortly about. The tumor-related pain in all this is not one of the most significant cause of pain in pediatric cancers, except at the stage where you are initially diagnosing. It could be a presenting symptoms, and then it could be at the time of relapse or during the end of life care. What about the bone pain? The bone pain is caused by the medullary expansion rather than by the localized bone metastasis. In children, usually the cancer does not metastasize to bone, but because of the ALL, there is actually they are all blood cancers, and therefore because of the expansion of the medulla during the active phase, they have lot of pain which needs to be addressed. So the bone marrow pains in hematolymphoid malignancies is a severe and major pain in pediatric cancers. Neuropathic pain, it is less common as compared to adults. It is because of the injuries to the nervous system, which is caused by vincristine and radiation rather than by any primary lesion. The cord compressions are also less seen in children, except in the AML, where it can be a presenting symptom caused by a compression of scleroma. So what should be the route of administration? As Dr. Komal has already discussed about this, oral is always the preferred whenever possible. It is least invasive, so it is more accepted by the child. Intravenous and transdermal are the accepted routes of the administration when child cannot swallow. Intramuscular is not recommended. One is because of the fear of the child for the needles. But more than that, in oncology, it's because of the low platelets, coagulation disorders, and because of the neutropenias, you are avoiding multiple injections. Rectal administration, again, is completely not used in an oncology setup because there is a theoretical possibility that the rectal administration or handling can cause the bacterial translocation and subsequent bacteremia in neutropenic children. So patient cooperation to be maintained is extremely important in all children, but more in oncology because of the repeated exposure. So always give them reward therapy, have rehearsal. It may not be possible. Counsel the parents and always take parents in confidence and make them present at the procedure location, at least during beginning of the procedure. Use distraction methods, give children the choice of induction. The older children do demand that I don't want prick or I want prick sometimes because they don't like sevoflurane, and avoid overfasting. Overall, make the experience less traumatic or unpleasant. Otherwise, they will not come for the next therapy. Regarding procedural pain, it's mainly repeated exposure to the pricks. Daily, they undergo 3 or 4 times, even the electrolyte checkup, then daily CBCs. The chemotherapy goes every week, so they come for intrathecal injections every week. So multiple pricks throughout. So vascular access is yes in most of the time in C2 to avoid at least the blood-related pricks. But for other pricks, used always the skilled operator. Along with the sedation and general anesthesia, or otherwise always use EMLA creams and smaller needles. A short word about a chemotherapy-induced peripheral neuropathy. I think it was discussed in the neuropathy webinar last time, the neuropathic pain. But incidence of neurotoxicity related to chemotherapy is around 3 to 13% in children having cancer. And in children having acute lymphoblastic leukemia, that is the hematolymphoid malignancy of the child, it is almost seen in 35% of these children receiving the chemotherapy. And what are the major drugs? They are the platinum-based compounds, that is cisplatin, oxaliplatin, the taxanes, paclitaxels, vinca alkaloid, mainly the vincristine. These are the 3 important group of drugs which causes chemotherapy-induced peripheral neuropathy. And they could be sensory motor, they are dose-related and cumulative. Along with that, the long-term functional abnormalities of structural regions in both peripheral as well as in central nervous system are seen following the chemotherapy. There is no gold standard diagnostic test like documentation either by skin biopsy or nerve biopsy or by nerve conduction studies, etc. There is no proven strategy or intervention to prevent or limit the development of chemotherapy-induced peripheral neuropathy. So there are grades of chemotherapy-induced neuropathy, and when the grades are more than 2, so the grade 2, 3, and 4, they are treated with the drugs via gabapentin, amitriptyline, as we know. So the other issue is mucositis, chemo-induced and radiation-induced, and it is also graded in 0 to 5 grades or 1 to 5 grades. And when the mucositis is there, it causes abrasion of the oral mucosa. So the swallowing and eating becomes very difficult. At times it causes ulcer, and in severe, they get infected, which leads to severe pain, and it completely stops the oral intake of the child. The child can become hypovolemic, goes in hypovolemic shock, and it becomes emergency. So I'm not going in the details of the mucositis therapy, but again, it is a multimodal therapy where oral hygiene, along with that, if it is so severe, even the systemic opioids are required. So most preferred one is if the child is taking something oral, we can go with the oral morphine, or otherwise, if the child is in grade 3 and 4 mucositis, most of the time the fentanyl intermittent boluses or patches are required. What about opioids in children? Dr. Komal has already spoken about it, but morphine and fentanyl are most studied in cancer and chronic pain. We know that the pharmacokinetics and dynamics are different in child as compared to the adults, and they have faster clearance except in small infants in less than 6 months. So they require, and they have higher volume of distribution, so they require more loading drug of the opioid. The respiratory depression, Dr. Komal has talked about. We should be vigilant, but we should not be worried. And because the child may have respiratory depression, not giving opioids or morphine to the child is really not, it's not a good practice. So what are the indications of weak opioids? So the codeine, pethidine, tramadol, and other agents, now they are out from the WHO ladder. The problem with codeine, we know that it requires enzyme, so that the codeine is with which the codeine gets converted to the morphine. This enzyme is lacking in neonates and less than 25% of the children. It is of almost 1/4 value as compared to the adult. So the analgesic effect of the codeine is absent in neonate and in young children. So therefore, it is gone out from the WHO ladder in the newer ladder. The pethidine, it is not recommended for the repeated boluses because the norepinephrine, which is the metabolite of the pethidine, which causes CNS toxicity, it is also considered inferior to the morphine. And low doses can be used for the prophylaxis for rigors, but otherwise for pain medicine, it is not much used in the children. Tramadol, there is insufficient data. So as we know that earlier it was a 3-step ladder, but now we have moved to 2-step ladder, in which the first step is for mild pain, in which it can be managed with paracetamol and ibuprofen. The second step is directly to move to the strong opioids. So we have to take constant efforts to prevent the child going in the chronic phase, which leads to the psychomotor atonia, where the child stops actually expressing about the pain or talking. So summary, cancer pain comprises of multiple factors. In this, the treatment pain is much more than the tumor pain itself. The long-term effects are seen in the survivors, because these are the childhood malignancies, and the survival and rate is so high. Now the long-term effects are now seen of the chronic pain following the chemotherapy and oncology treatment in the survivors. Opioids in children are not more dangerous than in adults. We have to have a holistic approach, and it needs a good teamwork, which comprises of a pediatric oncology, pain medicine, and palliative care. Thank you.
Thank you, Dr. Madhvi, for that very crisp and informative talk. My sincere apologies if I have not moved your slides at the right time. It's all my mistake. But for the audience, please know that these slides will be like it's a recorded webinar. So definitely you can go back and see it on the ASPA website or our Facebook page. I now invite give me a minute. I now invite Dr. Spandana Raila. I'll be sharing my screen. Yeah. Yep. I hope you can see. Dr. Spandana, can you see my slide?
No, Anu, but that's okay,
Okay.
I think. If you
No,
cannot.
just give me a minute. I'll fix it. Yeah. Yeah. Is it seen now?
I
Yep.
cannot, but I'm not sure if Andy or Madhavi can see.
Oh,
Anu, I will share the slide.
okay. I'm so sorry. Okay.
We
Yeah.
can see the, yeah.
Okay. I have had the pleasure of meeting Dr. Spandana Raila in one of our surgery classes a couple of years ago. And I think thanks to social media and our common interest, we've been friends since then. Dr. Spandana is she's done a pediatrics followed by pediatric palliative care. She's an educational lead for the Sunflower Children's Network, Two World Cancer Collaboration. And she's currently at Bayat Abdullah Children's Hospice Center in Kuwait. Her areas of interest are global child health, access to pediatric palliative care, and ethics in pediatric palliative care, especially socio-economic, cultural impact on delivery of pediatric palliative care. She's also involved in various education programs regarding development and delivery of pediatric palliative care. The podium is all yours, Dr. Spandana.
Thank you, Anu. It is definitely a privilege to come back and work with people I have known over years now. So thank you for that. And yesterday was International Pediatric Palliative Care Day, and today is a World Health Hospice and Palliative Care Day. So excellent coincidence, and I'm very grateful to be here. And I thought this should be a good slide, but then I saw all those wonderful questions coming up on the Q&A, and I realized people are paying a lot of attention. But I'm very glad to be here. The reason why I think I'm glad to be here is, in my experience, so my background is pediatrics, right? So anesthesiologists are the one who are always approached for good pain management. And whenever we meet ones who are trained in good pain management, we see that the children benefit a lot. And a lot of times, also the opioids are completely under the control of anesthesiologists, which becomes very, very important, especially in cancer pain, to control their pain to some degree. So very grateful that all of you on a Saturday afternoon are spending your time here. For this talk, I was just thinking, what does even an intervention mean? And Merriam-Webster says that anything that interferes with the outcome or even the course of condition or process. So that is why when you hear about some of the interventions we talk about, you can see why I went to the breadth of it rather than the depth of it. So whatever changes the outcome of whatever is happening in a child's pain is going to be an intervention. And before moving the slides further, I just want to say a lot of the questions are concentrated on pharmacological management, opioids. So I would like to just address that before I go further, because I want that to be at least something to be cataloged for future discussion. So opioids are quite safe in children. And when I say children, I even say children who are born preterm, children who are born at 28 weeks of gestation, 26 weeks of gestation, we have used opioids. But we need a little more training about what the dosage should be, how frequent it should be, and things like that. But opioids are quite safe in children. And a lot of you have asked cancer pain, what is the guidelines? WHO has guidelines, but what we have to remember is at the end of the day, there is no one drug that is going to do everything, right? So there should be good assessment from our side, kind of say whether it is nociceptive pain or neuropathic pain. And based on the condition of the child, we would say this drug is better for this child. Some of you asked about Kasai's procedure. I'm sure you asked that because liver is involved. So we are looking at the function of the child, the condition of the child, the diagnosis of the child, and where they are on their disease trajectory to choose a drug. and that becomes very important. So I think one thing all of you are asking about is interventional procedures, and I'm not at all surprised because you're all anesthetists, right? So, and anesthetists do interventional procedures. And one thing we have to remember, as I said, it becomes very important when you're selecting, especially pediatric palliative pain for interventional procedures. What is the disease in itself? It's not just the pain that you're going to treat. So what is the prognosis? How long do we expect this child to live? And what are the expectations of the patient and family? Are they expecting like 100% relief, or they're saying even if you can decrease 50% of the pain, that is enough for us? Or they're saying function is the most important thing, we don't care about the pain and things like that. So that becomes very, very important. And when a palliative care physician comes to you, or a pediatrician, or even a pediatric oncologist comes to you, it is very important that we discuss among each other as physicians about what is it we are trying to achieve for this child. And then, as you all know, there are non-destructive procedures that you can offer, destructive and non-destructive local anesthetics with deposteroids for longer action, or even using a catheter to deliver local anesthetic and plus or minus clonidine. And there's a new drug called zeconotide, which acts on calcium channel. And then the destructive ones are the chemical agents, alcohol and phenol, and also physical methods such as radiofrequency cryoablation. Cryoablation hasn't been studied so much. And then surgery in itself as an interventional procedure. And then again, peripheral nerve blockade. There is limited role in cancer pain management, but I have added the resources on a different slide. There are few studies which says it helps. There are few studies which say they don't help. And then again, this includes giving a bolus injection of a local anesthetic plus or minus a deposteroid. But then again, there is no evidence for steroids at peripheral nerve blockade, at least in children. And then catheter infusions for brachial plexus or other nerves. And then other than peripheral nerves, thinking about just autonomic nerves, especially for abdominal cancers. Most of them you don't see so commonly in pediatrics, but I think a lot of the pediatric evidence is gathered from adult experience. So here are a few of the autonomic nerve blockades that are done. And then neuraxial blocks, epidural and intrathecal. A lot of you have asked questions about epidural. So again, I have worked in a resource limited setting, and I also work in a resource high setting now. So my experience is epidural and intrathecal, when especially it's resource limited, I think it becomes very, very challenging. One, because of the cost in itself. Two, because of high risk of infections that might happen post doing the procedures. So that is the other thing. And three, a lot of times, again, this is one thing I answered on the Q&A. We start with pharmacological. 99% of the children respond. Again, this is anecdotal. I don't have evidence to back this up. 99% of the children respond to the drugs that we are giving orally or through injections. But there are few percentage of children who do not respond. And they might be the ones who might benefit from the procedures in itself. And then neuraxial infusions, such as again epidural, intrathecal, these are continuous ones. Right now, I have a child who's on intrathecal plus epidural plus a PCA pump plus high doses of methadone, right? So once every few years, you get a very complex pain child, and you might need to use this. But saying that intrathecal is going to be absolutely useful or epidural is going to be absolutely useful, I don't think it is true, because this child, my anesthetist who is managing the intrathecal pump is telling I'm giving horse doses of drug for this boy and it is not helping. So there is no such thing that do this, the pain will be absolutely gone. So just to be mindful that these are not cure-all, do-all kind of procedures. And here are two interesting articles that I found which were published last year. And they do have a lot of how many percentage of children have responded to what. And they do recommend them. But again, be mindful what the condition is, where in the disease trajectory the child is. And these procedures do come with side effects, and they are not side effect free. So the family has to be allowed to say yes or no, and to weigh the benefits versus the risk that these procedures involve. And then I thought, hey, these are all anesthetists, and what am I going to talk to them about, interventional procedures, because you are more experienced in this than me. And then I was thinking, what are the other things that are interventions? And then I have found tools. And for example, even before I talk about the PediQuest tool, think about some of the tools Dr. Tewani has shown. These are pain scales, right? So the moment you start documenting, for example, a neonate, that, hey, this child has 6/7 pain in NIP scale, it becomes imperative that we treat that pain because it is 6/7, which means it is severe pain. And that itself is an intervention, documenting that the baby has pain. And then you start the baby probably on paracetamol, and the pain comes down to 5/7 or 4/7. And that shows you that paracetamol probably is not the most effective drug. And then you're thinking, okay, what is next in my options? And you are saying probably opioids are better. And that itself becomes another intervention. So just using pediatric palliative care tools and PediQuest tool, I have added the reference here, and they have used reports from parents about how the quality of life is affected, and using the scale help them improve the quality of life in itself. And then surgical interventions. A lot of times, again, to remember that things like gastrostomy tube, especially when swallowing itself becomes very hard in conditions like epidermolysis bullosa, which a lot of people wouldn't think of as a pediatric palliative care condition. But in my experience, it can be pediatric palliative care, and they do develop strictures of their esophagus, and it becomes very difficult to swallow. And getting a gastrostomy tube changes their life and helps them increase in their weight and helps decrease infections. So a surgical intervention can make a lot of difference. Again, the reason why I have thought this becomes very important is coming from a South Asian country with resource limited settings. My mind was always thinking that let's not put these children through a lot more procedures. Let us protect them from procedural pain. Let us protect them from unnecessary hospital admissions. But then the research, and as my experience expanded and probably my mind expanded along with it, that not always surgical interventions are bad, and especially in non-cancer pediatric palliative care, the surgical interventions can actually prolong their life. But then, is prolonging life enough, or quality of life also equally important, is something we do have to discuss. And then a lot of times when resources are available, again, this is from the USA, this paper. So they have said they usually undergo at least one surgical intervention, and they are not to be considered futile because they are associated with longer survival. And then Dr. Tivani has mentioned few of these before. And along with pharmacological, such as opioids, paracetamol, it becomes important to use non-pharmacological pain management techniques like swaddling, nesting the baby, kangaroo mother care, breastfeeding whenever possible. Breastfeeding is even recommended during vaccination, right? So sucrose drops. But for children, there is something called guided imagery, where you ask them to close their eyes, think about a happy moment or a moment they felt at peace, they had a great time, and you walk them through the whole thing. And then cognitive behavioral therapy, such as biofeedback, these are very important in managing pain, especially when they have to live with pain for long duration. And then I was looking at trying to find more evidence about interventions, and I ended up going through the rabbit hole. And one interesting thing I thought was communication itself is an intervention. So goals of care discussions, what is it the family wants, especially when it is cancer and even non-cancer. Advanced care planning, again, it becomes important because it decides the location of care. And when the location of care is different, the way we manage the pain becomes different. Including the route, including the drug, including how frequently they come back for refills and things like that. So all of these affect the pain management of these children. And then crisis planning, and even when the child is being born, where the if there is a perinatal birth plan, where the delivery is going to be, how this child is going to be managed, where the child is going to be. These are all important things to be documented and communicated among the team. And communication, it becomes very important that we listen more than we talk. And a lot of you have asked questions about communication. How do we talk to parents, especially with neonates of palliative care diagnosis? Again, a lot of times we think we have to prepare the family, we have to give them so much information, but it is us, and I'm sure Dr. Madhavi and Dr. Tivani would agree that it is us giving small bits of information and listening to what the parents have to say. And that helps us create a good care plan. And then I found something called family talk intervention. And it was very interesting because this was done in families where the adults are affected with palliative care conditions and children are part of the family members. So doing a family talk intervention brought them all to the same table, and the children could express their fears, their worries much better. And I was thinking this is something that could be translated to pediatric palliative care too, because a lot of times people who are suffering in silence are the siblings, the healthy siblings. Sometimes they get more attention, or sometimes they get less attention. And then there is a whole thing called digital health interventions in palliative care. I think this is to do with our COVID experience, but also even before COVID experience, because palliative care is not yet available and accessible everywhere. A lot of times there is video conferencing, we are maintaining electronic health records, and we are supporting families via phone. For example, Hyderabad, where I have worked for many, many years, after we get palliative care referrals, some of our patients go back to their homes, which are 500, 600 kilometers away. And that doesn't mean we stop caring for them. We stay in touch with them via the phone, and we call them regularly, asking them how they are doing, how the symptoms are, and things like that. So if you look at it, 15% of the communication on the phone in the study says that they talk about symptom management, and there is advice about that. And then the other interventions that we have to remember under a huge umbrella called complementary and alternative medicine. And I hope this slide is clear enough. It is about pet therapy. And I was interested to find out that they don't just call it pet therapy, it is called animal assisted interventions. And again, if you look at it, the mood, perception, and quality of life, and even the patients feel that their life is much better when they are allowed to interact with pets. But again, it depends, is it their own pet or is it a hospital pet, and things like that. And sorry, I think I'm pressing the wrong button. And then again, for pediatrics, a lot of times it decreases the fear about the invasive procedures that they have to undergo. And then there is art therapy. Again, children who have used art therapy have reported less pain. This is a 2023 study, if you can look at it. And then massage therapy. If you can believe, recently I attended a 6-week global academy, and 6 days global academy. And out of the 6 days, they have allotted 2 days for pediatric massage therapy. And this is all about pediatric palliative care. So definitely it is up and coming. And if you look at the numbers here, it says that the SOS pain medication usage, there is a difference after the massage. And then aromatherapy, again, they have used it for nausea and pain, and also the mood. If you look at it, what is interesting is that they made them smell something, and they checked the effect after 5 minutes and after 60 minutes. So with aromatherapy, the effect lasted even after 60 minutes. Whereas deep breathing, visual imagery, the effect was not the same at 60 minutes. So looks like aromatherapy is useful. Again, this is a recent study. And then acupuncture and acupressure. Truth be told, I was very skeptical. I have done a course 6 years ago or something on pediatric pain, and they said acupuncture works for children, acupressure works. I don't know if you know this, but the gap between our thumb and the index finger, so this point is where they say when you get a headache to use that. And then when you do this with your hand, like Spider-Man, there is a small depression that comes on your hand here. And this is the acupressure point for nausea and vomiting. And in the last 2 years, I have undergone acupuncture once for nausea and vomiting, and it did seem to help immediately. So the relief was immediate, but it's a one-time thing and it's anecdotal. But again, they are talking about doing more studies to understand more. And then music therapy. And I have seen again with my eyes that it makes a lot of difference. Here we have a music therapist, and it helps in management of the pain. And then always remember, the most natural thing for children to do is play. Uh, I mean, they might eat, they might not eat, they might sleep, might not sleep, but play comes very naturally, and it doesn't have to be a play therapy all the time or as an intervention all the time. Even letting them play itself makes a lot of difference in their lives. And that is something they lose when they are diagnosed with a serious condition. So even just thinking about how do we make play accessible to children who come to our OPDs, who come to our hospitals, who get admitted with us itself is, I think, a very important thing. And as you can imagine, it depends. There are several routes we can take to get different outcomes. And sometimes you want the cheese, sometimes you want the carrot, right? For each family, they might want a different thing. So based on what is it that they want, you bring in the interdisciplinary and multidisciplinary team and make sure that they have access to different modalities. And some of you have even mentioned multimodal analgesia on the Q&A, which was very interesting because thinking that morphine is a cure-all or takes away all the pain is not true. Or thinking that an intrathecal pump, just because it's very costly and it can be very effective, would be an answer for the pain of a child is not an answer. And then a lot of times, and I'm sure all the anesthetists and everyone who is involved with pediatric pain would know, no longer do we say pain is a biological model. We say we follow the biopsychosocial profile, BPP, for pain. And when we say that, it becomes very important, for especially for children, that their psychosocial status, psychosocial condition affects their pain perception. So remember, especially again with conditions like cancer and also non-cancer, they get separated from their own siblings, they get separated from their own peers of the same age group. And again, thinking about how do we have this learning and social integration as long as possible for these children. And here is another study that talks about it, but all I want to say is letting them have their connection decreases their distress, decreases their pain perception, and gives them a better quality of life. And then one thing we should not forget when we are dealing especially with family education and empowerment and pain is that just thinking about what are the drugs we are prescribing and what are the instructions we are giving the family and how we are asking them to store the medications, right? Because I know from Asia, we do not yet have opioid crisis in the same way that the West has. We have a different kind of opioid crisis of not prescribing, but just to learn lessons from the West and not to go the same path as the US becomes very important to explain regarding the medications from the start. These are special medications. This is only for your child. If you get a headache or if your other child gets headache, this is not a drug to be used. And this has to be always stored in a cupboard, which is not accessible to children. These become very important in pediatric pain, especially palliative pain. And then the other thing we all do have to remember is a lot of pediatric patients survive to adulthood, especially non-cancer and even cancer. They go into times of remissions and they might survive to 18 plus. And when they celebrate their 18th birthday, we usually transition them to adult services. And it becomes very important because as you can imagine, these children are very different from adults who get sick at adult age. These are children who have processed their disease in a different way. So just to remember that transition to adult services and it has to be very smooth, especially for conditions like sickle cell anemia. If you think about it, these children have been having sickle cell crisis for a long time, and they're using morphine and things like that. And if the transition to adult services is not smooth, their pain crises are not well handled, and they end up having a very bad experience during the next 2-3 years. And then just to remember that education itself is an intervention. For example, ASPA, the Pediatric Pain Special Interest Group, they are holding these webinar series as an intervention in itself, so that we build capacity and address pediatric pain much better. And families and children, they need to know that their pain and is to be treated, and relief from pain is a human right, and the child doesn't have to be in pain. That itself is an intervention, I believe, and communities at large to know that they should have access to good pain relief. And then just not to mention quality improvement, more and more, I think the world is talking about quality improvement programs. So especially because this is a pediatric pain special interest group, once we start doing pediatric pain management, we do have to remember how do we want to develop our program, how do we make sure that the pain is assessed well, and the symptom relief, and even the quality of services over a longer period of time, how they're managed. So I think we do have to remember all of these. And with that, I end my talk. Over to you, Anu.
Thank you, Dr. Spandana, for your lovely take on interventional pain management. Like as an anesthesiologist, I would just think of, where am I going to put the next needle, or what am I going to do, which opioid I can, or mixed maybe pharmacological approach. But I loved your wide take and multi-pronged approach to interventional pain management. I would like to call the house open now and take questions. We have been getting quite a lot of questions from the audience. That's great. But since Dr. Komal wants to, she has prior commitment, so I would want to specifically direct one question to her, where, give me a minute. They wanted to know about if there is any specific referral criteria for children or neonates for palliative care. So do you have specific criteria that you would want to refer this child for palliative care? Dr. Komal? Okay.
I think Dr. Komal is no longer.
Okay.
I will write the questions, and you all can see the answers from Dr. Komal in our social media or our website, ASPA website.
Okay. Yes, Dr. Addy, we can always do that. Dr. Spandana, if you want to take the question, great as well.
I was just thinking, I don't remember the British guidelines, but I mean, I cannot name the source. I will try and find it and post it on the chat. There are guidelines for it, and there are 5 categories of babies who can be referred for neonatal palliative care. And I just want to say, just to remember that extremely preterm babies, I know earlier we used to say things like definitely who are going to die, but no longer we say that, like trisomy 13, Patau syndrome, Edwards syndrome, Down syndrome. More and more, I think the life expectancy has increased, but still there are some children with congenital anomalies and other issues. Just to remember that any baby, even babies who develop NEC, necrotizing enterocolitis, babies who undergo surgeries for malrotation and huge gut resections. Just to remember, these are the babies. It is good to have a palliative care referral so that the family is prepared for a few things and the pain is well controlled. Even if you do not have a palliative care team, it's always good to have a meeting with the neonatologist, anesthesiologist about how we are going to manage these babies so that the family is well assured that their baby is cared for.
Dr. Spandana. I just have one more question, either for Dr. Madhavi or Dr. Spandana. If at all you're using opioids for neonates, neonates specifically, so what is the formulation that you have? Is it like a syrup, or is it crushed tablet, or is it specially formulated?
Dr. Madhavi, do you want to take it? Go ahead.
Madhvi, you're not audible.
You still muted, Dr. Madhavi.
Hello. Yeah. So there were again many questions regarding how to give fentanyl and morphine in oncological pain and palliative, whatever. But the first thing I will like to tell is these doses, when you start, give them in the monitored area, monitored environment, incremental and small doses, titrate. Then when you start them, call them back after a few days to see the effect, titrate again, and then finally they are sent on some regime when they are sent home. So it is always titrated incremental doses in the monitored area when you are monitoring their respiration, the effect of the pain, and then they are later on converted to the long-term doses or fixed doses. That is part one, because many participants had asked this. And the secondly, about your question, in India, as yet the syrup morphine is not available. So for children, we at least here we have to go with the IV medication or oral morphine. Fentanyl is yes, intravenous morphine or transdermal patches. Yeah.
Okay.
Dr.
Thank
Spandana.
you.
Yeah, we mix morphine tablets in normal saline or water, and we use it. Ideally, it shouldn't be mixed. It doesn't come with those instructions, but because we do not have any other choice, we do that. And we use 10 ml syringes for neonates especially, and we discard it every 24 hours. But as you said, morphine syrup, it is quite challenging in India. And the other thing is we could use injection morphine directly. But again, I think that itself, like opening the ampule and not using it completely would be wastage for us because we have so little access to morphine. So that would be a problem. IV, fentanyl, and even transdermal patch, I agree with you. But fentanyl, we also use sublingually or buccal also. But this is very short acting, as you all know. Therefore, we use it just before changing dressings, just before we are changing the child's position, especially if they have severe pain. So mostly for incidental pain, we use fentanyl as a very short-acting drug.
You still muted, Dr. Anu.
I'm so sorry. I hope I'm audible. Yeah. Thank you, Dr. Spandana and Dr. Madhvi. There are just a couple of more questions. So there is one pertaining to use of, can you use clonidine as for pain control? Can we also use Dexmed, which is in the same class for post-operative pain control in NICU? So this is as such not targeting palliative care, but do you also, I'm just curious to know, do you use Dexmed in palliative care?
We use Dexmed in palliative care. A lot of times people are scared to use it because it's a very ICU drug, I believe. But I think more and more we use Dexmed. All I want to say is clonidine is available in oral form. And I do not have to monitor the baby continuously when I use it. So that's why I think clonidine is the one we use as first line. And Dexmed, the experience is via IV line or subcutaneous line. Therefore, usually tends up being a drug which we use at hospices, like physical buildings where we are monitoring these babies. So that is a huge difference between the two. And Dexmed, again, I think because of the side effects, especially most of the times these children are already on opioids and they can have the synergistic effect. We reserve it for end of life or probably even intractable symptoms, even though it's not end of life, rather than being the first line drug.
Okay. Yeah. Thank you, Dr. Pandana. Dr. Addy, do we have some more time to take some questions?
I think we still have like 2 minutes for
Okay.
questions, I think.
Anu,
Okay,
can I just say that so we offer a pediatric palliative care fellowship through our charity organization called True World's Cancer Collaboration. And Adi had shared the link with you people. If any of you, but it is offered only for pediatricians, I'm sorry, because so if you are able to apply, if you're interested in pediatric palliative care, please look at the link and please write to us. Tomorrow is the last date for application, but we would be very glad to look at your application. And it is offered for South Asia and Southeast Asia because the classes are in early in the morning. We cannot offer it globally, but I'm sure like this year we got a good number of applications from different countries. So if anyone is interested, thank you.
Thank you, Dr. Spandana. I was just about to ask you to talk about your Two World Cancer Collaboration Center, which is doing great work in India, in Southeast Asia, rather, Bangladesh and India, and I think Nepal as well. Yeah, thank you so much. Yeah.
Sri Lanka and Bhutan this year too.
Oh my God, that's lovely. That's lovely. Yeah, that's great. I honestly think we need to be the fiercest advocates for children who are under our care. So it could be acute post-operative, it could be any kind of pain, and more so because, like you mentioned, there are very few voices among pediatric pain communities. So I think we just need to be loud, make sure that these children are not denied of the basic right for pain management and treatment. Thank you so much.
And platforms like this, I think they're very heartening to all of us who work in this, because like, having 100 people from all over, Asia coming in on a Saturday afternoon and trying to understand more about how to help children, I think that is wonderful. So thank you for that.
Yeah. Thank you to everybody. Thank you, Dr. Andy. I think, is it a good, we'll call it an end, and I'm sure all the audience have been with us patiently for the past 2 hours, and I sincerely extend my heartfelt thanks to all of you. And to conclude, I would say, this is a pediatric palliative care is as such a heavy topic and a difficult topic. We have tried to do justice to it, and more. We have left a few of your questions unanswered, but trust me, we'll get back to them. It will be available. The answers will be put up on the ASPA website, the PPSIG website. So just don't be disheartened that these questions are just left here and not hanging. Just because of short of time, we'll have to, we're cutting this short. And I just also need to share a couple of more screens. So please do send us your feedback. You can scan this and send us. And obviously the next year we're going to have again a series of classes. So please give us your ideas. If there's something that you're really interested in listening to, then just give us your feedback. So we'll try to provide that content. Like I mentioned, it's a recorded webinar. You can always visit our website, Facebook or YouTube and follow us. Next slide. Yeah. And this is an ad for our next 5th ASPA Flex webinar, which is about challenging pediatric neuroanesthesia cases. This is going to be on the 18th November, in a couple of weeks. So it's for free registration. You can scan this QR code and register for this unique webinar. Adi, could you please go to the next slide? Yeah. Like I mentioned, so this is going to be the last webinar for this year. Do give us your feedback about various topics or areas of subspecialty interest, and especially neonatal pain, integrated therapies, or CRPS. Most of this literature comes from the West, so we would be very happy to look at studies which are coming from Southeast Asia. And just a reminder, please join us on the 11th of November 2023 at 4:30 p.m. Singapore time to hear Dr. Professor Alan Finley speak on "We Can't Do Everything, and Anesthesiologist Needs Partners." So all nursing, allied health, non-anesthesiology clinicians, whoever is interested in pediatric pain are invited to attend this webinar, which is going to be followed at 5 p.m. by our 3rd annual general body meeting. So listen to what we have been busy doing for the last entire 1 year. You can also get a chance to meet the new council and vote for the direction in which our special interest group will take in the next few years. Thank you so much for joining us today. Dr. Harry, the next slide, please. Yeah. So yeah, obviously we would want more of you to join the pediatric pain special interest group. At least we probably have around 30 or so far. And then, I mean, all our webinars, we have had 100 plus or more attendees. So I kindly request you use this code, scan it, and do join the community. Our next ASPA conference is in Kuching. That I hope I'm pronouncing it right. That's in Malaysia. That's on the 11th to 14th of July 2024. So please go ahead, block your dates, and do try coming to this ASPA 2024 web live conference. Yeah. We'll see you again next year for another set of educational programs. Do visit our ASPA website and social media for more information. Thank you so much.
Thank you.
Dr. Addy, do you
Everyone.
have?
Yes.
I think we call it a day. Yeah. Can go
Yeah.
back to enjoying the India Park match, I guess. Bye, everybody. Thank you for
Bye.
joining us.